Good evening. Welcome to UOA On Demand. My name is Ravi Verma. I'm one of the orthopedic spine surgeons at University Orthopedic Associates. I am joined today by my two colleagues, Dr. Gino Chiappetta and Dr. Matthew McDonnell, regarding an important topic in spine surgery. We will be talking about annular closure devices and how that may play a role in your spine surgery care. The first question I'd like to direct towards Dr. McDonnell is, what is the major problem here that we're trying to solve with an annular closure device?
Yeah, so this is relevant for patients with lumbar disc herniations. So if you have a lumbar disc herniation where the herniation's pinching a nerve in your back and you're having a lot of back pain and a lot of nerve pain, we can do a very sort of successful, reproducible, reliable surgery where we go in and we basically remove that herniated disc fragment, get the pressure off the nerve, and patient outcomes after that surgery are generally really, really good. One of the potential issues going forward after these operations is the risk of re-injury to the disc or re-herniation. So what happens is when a disc herniates, we talk about the disc being like a donut, right? And a disc herniation is sort of like the jelly coming out of the donut, and the material goes into the spinal canal and it pinches the nerve. So surgically we go in and we can remove the jelly or the herniated fragment from the spinal canal and get the pressure off the nerve. But there's always a little hole in the back of the donut that the herniation came through. And because there's a little weak spot in the back of the disc or the back of the donut, there is a chance that going forward that disc could get re-injured and you could herniate a disc again. And we call that a recurrent disc herniation. It can happen in anywhere from 5, 10, 15% of patients that have lumbar discectomy surgeries, depending on what study you read. And it would be nice if there was something we could do surgically to reduce the patient's risk of having a recurrent herniation. For many, many, many years, they've tried all sorts of techniques like suturing it, cauterizing it, plugging it, filling it, and many of those things have not proven to be very successful. The Barricaid is sort of a new device designed to try to treat that problem.
That's really important. And I guess, Dr. Chiappetta, do you have any insight as to maybe how the Barricaid works, and have you found that it's effective?
Sure. So like Dr. McDonnell alluded to, it is a device that is used in specific instances where we feel that the defect in the area of the disc that ruptured can be strengthened and reinforced with this particular device, which can help reduce the risk of the disc suffering the same fate of rupturing and herniating a second time. And the device is very unique where it is anchored into the bone. So part of the device will actually anchor itself into the back part of the vertebra. And we do it with X-ray in the operating room, and we're keeping an eye on, we're visualizing this directly into being implanted, and then it will deploy and release, and almost like a mesh polymer opens up, almost like a big parachute, and will deploy while you insert it, and it will act to almost basically plug the back of the disc to help reduce the risk of a piece of disc rupturing through that defect again. So it is made part of metal titanium, which will implant and anchor itself in the vertebra. And since it's anchored in there so stiffly and so securely, we don't worry about it moving. We don't worry about it fracturing. So it's a very secure device.
So Dr. Chiappetta, are there certain patients that you think that qualify or would benefit from this kind of procedure? Or is this something that all patients with a lumbar disc herniation would benefit from? How do you decide who would benefit from this and who would yield the most results from this?
Sure. So it's not necessary to every patient who has surgery for a herniated disc. Patients that have a higher recurrence of herniated discs are certainly younger patients because they're more active and have a much higher report rate of recurrent disc herniations, which can be up to 20 to 25% of the time for adolescent and young adults. Patients where the disc herniation has sort of a wider base to it are also patients we tend to use it for, because that means the defect in the back of the disc is going to be much wider and makes it more prone to re-herniating in the studies. And the device actually looks like this, where we can see where the metal piece here will be anchored into the vertebra, and then it deploys, and the polymer mesh will open up and introduce itself into the actual disc and act as the plug to seal up the defect.
So, I mean, Dr. McDonnell, you know, we're talking about a new device here, and we're talking about the problem of recurrent disc herniations and reherniations. You know, if you don't go down this route and try to prevent the reherniations with something like a Barricaid, you know, what's the big deal? You know, you get a reherniation, so just get another discectomy. Why is it important to try to prevent a reherniation?
Well, obviously disc herniations come with a lot of, pain and pain related disability and, lost time from work, lost time from enjoying activities of life. So obviously to minimize the risk of that happening is obviously a big advantage, for our patients. If we, in the situation where we're not using a device like this, or maybe you're not a candidate for this device, I mean, we certainly talk about, post-op activity management strategies to reduce your risk of a disc herniation. We all kind of talk to our patients about avoidance of the BLTs, the bending, the lifting, the twisting for a certain period of time after surgery. If we operate on an athlete, we're sort of taking a measured approach to when we let them return to certain, aspects of their sport and training. If a recurrent disc herniation does, occur, obviously it can be very painful, like the initial herniation often was. Sometimes we can treat it successfully without surgery, like we sometimes do with regular disc herniations, but these do tend to have a little bit of an increased likelihood of requiring a surgery. More often than not, we could do what we call a revision discectomy or a revision laminotomy discectomy. We're basically going through the same incision. We make, a similar opening in the spinal canal. It could be technically a little bit more challenging because there's going to be some scar tissue present from the prior surgery. But usually we could go in there, make another small opening, and scoop the herniated fragment out. There are occasionally some really unfortunate patients where maybe a recurrent disc herniation will happen multiple times, or the herniation occurs in an area where it can't be removed with a minimal operation. And sometimes those patients end up going on to a spinal fusion operation to basically permanently remove the disc and stop that problematic area from moving.
Yeah, so I think that's really important to bring up, because if somebody has multiple reherniations, probably not just one reherniation, but multiple reherniations, they're at a higher likelihood of needing a bigger surgery like a spinal fusion. So if a Barricaid type of procedure can limit that outcome from happening, that may be in the patient's best interest.
Yeah, I agree, because it's the whole morbidity that goes along with it. If a patient has a second disc herniation, those can be extremely painful. Going through that experience a second time can be quite debilitating, missing more time from work, having a long recovery, needing a second surgery, all these things that the cost to it, obviously it's, the cost of missing work, the cost of a second surgery to patients who have, out-of-pocket expenses many times with large deductibles. They're all things that we have to consider, because we're trying, I always try to do one surgery on a patient, be done with them forever. So if we can achieve that with something that has a very high safety profile, a very good short and long-term data, excellent randomized clinical trial results, I mean, to me, it's like a no-brainer.
Yeah, I think it's a great point. And obviously anything that we can do to be more minimally invasive and not expose the patients to more risk, because obviously revision surgery still carries some additional risks like Dr. McDonnell pointed out too. There's some scar tissue there. There's potentially an increased risk to an infection. There's probably an increased risk to like a dural tear. So, anything we can do to limit those exposures will be beneficial to both the patients and ourselves.
This is something we should probably point out, requires an extra insurance authorization and approval. And so, if we thought, one of our patients was an appropriate candidate for it, we would work with the insurance company to see if we can have it, approved, if we felt, appropriate indications and criteria were met.
Dr. Chiappetta, what are the additional risk factors or limitations or restrictions that a patient who has a disc herniation and has a Barricaid put in versus somebody who just has a disc herniation that is treated traditionally?
Sure. So my experience in using this device, it takes approximately maybe an extra 10 minutes or so on the surgery, so nothing significant. In my experience and in the medical literature with all the data compiled by doing, there's been over like 8,000 implants in the world. There's no increased risk in infection. There's no statistically significant increased risk in nerve injuries. So the safety profile is excellent, and it does not cause any hindrance to the recovery. We treat them just like any other patient that had microdiscectomy. And with them, I personally feel I allow them to do things sooner and quicker because I feel like that the disc is being protected already. So I allow them to drive sooner, to get back to work sooner, start to exercise sooner. So I think if anything, it has more advantages than a standard discectomy.
I want to thank Dr. McDonnell and Dr. Chiappetta for their time tonight in talking about this very important topic. I want to direct all patients to the University Orthopedic Associates website if they would like to speak with one of our spine surgeons about a possible lumbar discectomy or even an annular closure device like Barricaid.